Hi everybody, this is Brad. I wanted to send you a video and tell you about something that we are trying to make a big change to, which is how we report what happened overnight to the neighborhoods. And there's been a lot of, I heard a lot of issues about a duplication of work. And so I know that the coordinator's doing the big visit log and also doing the virtual board. Those are very similar. And so what I've talked to Marion and Ladina about last night was making just one form, getting rid of the virtual board and sending it to the neighborhoods. And I've talked to most of the clinical supervisors about this, so I want to show it to you. So take a look here at this document. This is an Excel document, and this document includes information that's really on the visit log now that we transcribe over to the virtual board. But we've also been putting starts of care and scheduled visits that the neighborhood census. They already know their scheduled visits, so it really isn't our responsibility to tell them the scheduled visits that happen. That's their responsibility to know the visits and started care visits that happen that they've already done, because they get reported to the team. So we need to focus really on the unscheduled visits that occur overnight and make it more efficient for our team here. So this document at the far left, you can see that we're looking for the date that it occurred on, and we have to be really accurate with that because we work overnights, so the date changes at midnight, so that's why we have to be particularly observant. The patient name, the patient ID number, the team number. This will be very important here in a bit. The time of the call. I have the, notice 5 p.m., 2 a.m., 6 a.m., 5 p.m., 5:10 p.m. And the issue or the request type. Now, some things we're going to be reporting on to the coordinator are not necessarily visit requests, but also hospitalizations, any changes, or if level of care. For instance, if a patient goes if the patient goes to Adler or Hallquest, we want to make sure that that gets notified to the teams. If any GIP level changes, level of care changes is in any way, or if one of our patients goes to the hospital, that definitely we want to make gets reported. So, for instance here, the caregiver reports patient's agitation at 5 p.m. Next, for Mary Jones, the family reports the patient's in a crisis, pain crisis at 2 a.m. And again for Mary Jones, at 6 a.m., the family has reported the patient's death. Now, Peter Henry, caregiver reports the patient's pain crisis, and 10 minutes later, the caregiver calls us back and reports that the patient is leaving 911, nurse notified to visit Fairfax Hospital. That's because we need to make sure that if our patients go to the hospital, we go. What's been happening down for Molly Brooks is that the hospital is upset with them because they have so many patients from hospice who are leaving that hospital, going home, and coming right back. And their intention when they refer to us is that we'll be able to do the best job we can to keep patients at home. But patients are showing up at the hospital and our folks aren't aware of it and not visiting the hospital. That is not the case for Virginia Hospital Center. I'll make that clear again. Virginia Hospital Center, we only go if we're called. That's a collaboration that Carolyn Richard has worked out with the hospital. Next column, time of confirmation. So I confirmed with Nurse Sarah at 5:15 that Nurse Sarah, is going to make a visit. Time of confirmation. And here all the way at the bottom, I confirmed at 5:10 p.m. that Peter Henry is going to get a visit by the nurse confirming, Nurse Jenny, at 5:10. And we know the nurse is visiting Fairfax Hospital, the ER. So that's the column all the way here at the end. The second part, I try to make it a little easier for anybody who goes to Adler. So for instance, on the date, I don't know why it looks like that. So let's see if I can fix that. On July 1st, 2016, these are all obviously examples and it keeps changing. I'll fix that. Henry Loans, with his ID number of team 1014, this patient transferred to the Providence IPU for pain and agitation. And the time of this change was 6:45. This helps us to keep a good flow. We had a patient who ended up in Providence IPU in DC, and I think the patient came from Virginia a few weeks ago, and DC was surprised about 8 hours later, the DC office, that the patient arrived. They had no idea how the patient got there. So this is one step in helping to prevent that from our folks here in Care Navigation. I mentioned earlier the importance of making sure that we have the team numbers, right? So if you go over to the far left column and go 4 columns over, you'll see the team number. What the coordinators are going to do, what the clinical supervisors are going to do when the coordinator sends this to them every morning, instead of sending the virtual board, they're going to filter out their team. Notice all the team numbers. Now I'm going to go to data. Now the clinical supervisors know how to do this. Data, and we are going to sort A to Z, and I want to always expand the selection. That means that all this information to the right or left stays the same for Mr. Payne in 1214. So notice that he called at 5 p.m., for example, Tom Payne. Now we're going to sort. Okay, so all the team numbers in 1014 are in the top, so the clinical supervisor reports that to their team instead of using the virtual board. And this is the clinical supervisors again doing this. And Tom Payne, remember, at 5 p.m. in team 1214. So the ultimate goal of this is to make it more efficient and less duplicate for our team in Care Navigation. Thank you, and I hope you're all great.